Hi, everybody. Nico here from Redox. Really excited to hang out with all of you guys today. To start off with and get familiar with how this works, use the chat on the right side of your screen there to say hello. Like Annie mentioned, you can let us know where you're calling in from. It looks like a lot of diverse locations here, including Nick from Kauai, which is awesome. Thanks for calling in, Nick. Annie's sitting with me here in the room. You can see her here. And that's James, who's also here. So what we're going to do is kind of run through a bit of a presentation, and then we'll hang out and answer questions at the end. So feel free to keep chatting on the side. Also, if you have specific questions that you want me to address, throw them down in the questions below. So there's a big orange button that says Ask a Question. Throw them there, and we can definitely address those. I see some of you already putting questions in there. So if you see questions that you like, vote them up and down. And we can definitely hit those at the end. So we'll get started. As many of you saw this past week, we closed another round of investment. We announced it to the world, our Series B round of financing. This is us with our new investment team at HumanRe Ventures out in New York City. And the thing that I love about the fundraising process is that it forces you to pick your head up from the day-to-day and reflect on where you came from and where you're going as an organization. In this process, we attempted to document what we've learned over the past few years as trends start to emerge. So I'd like to share some of those observations with you today, as well as lay out where we think technology adoption in healthcare is going. As many of you know who have worked with us over the years, Redox is designed to help technology get into the hands of consumers and patients and providers faster. We're trying to streamline that process. So we've kept our ear to the ground on how that process has developed and are seeing some interesting trends. So to back up and kind of give a little history of where technology adoption in healthcare came from. So we'll kind of start there and then go through where it is today, and then where we think it's going. So at the core of this problem are essentially the misaligned incentives in healthcare. I got really interested in this in graduate school. It's what drew me to Epic. It's what drew me to the healthcare industry in general. But really, when we look at this three-legged stool of providers, hospitals, and payers, the incentives behind these guys were and still are in a lot of ways at odds with each other. The fee-for-service world meant that doctors had the incentive to offer more services, hospitals wanted to fill more beds, and payers wanted to limit what was covered so they could make more money. And what this led to over time was the status quo of increasing costs. We're at a point where we have nearly a fifth of our GDP is spent on healthcare, tremendous amount of money being spent. The increasing costs contributed to adverse selection, which is essentially healthy people dropping out of the insurance market because it wasn't a good deal for them anymore. Those people dropping out actually made costs increase because they weren't there to essentially pay into the pool of money that was to take care of the entire population. So that created this adverse selection spiral, if you will, that really started causing a larger portion of the population to become uninsured. And then within all of this increasing cost, there was a tremendous amount of waste. So this is, over the past decade, we've seen this trend coming on. And this graph here represents the different buckets of waste in the industry. So the Institute of Medicine put this out in 2012 using 2010 data. But essentially, each of these segments are a bullseye for entrepreneurs to create new technologies to tackle them. So what we've been seeing was that as we look at the waste in the industry, there's a lot of technology out there that's focused on tackling that waste. From a government perspective, there was a policy put in place that said, okay, we have a lot of this waste. We can tackle that through technology. And the technology that was pinpointed in tackling that was the electronic health record. So this sort of first wave of technology adoption that we saw in healthcare was the mandated adoption of the electronic health record. So pre-meaningful use was the actual policy to help to subsidize the adoption of medical records. Pre-meaningful use really electronic medical records were at the edge of that chasm. Early adopters, big academics, integrated delivery networks, the HMOs that still were out there were using EMRs. But as the government, through this policy, encouraged the adoption of medical records, and that in a way dragged the adoption of it over to the early majority and late majority where we are today. Now, fast forward to today, EMRs are used across the entire industry. They're at a point where we're in this laggard portion of it where the skeptics are adopting medical records. We're also starting to see those early adopters optimize their medical records and get them to a point where they're trying to eke out more efficiency gains with it. But at the end of the day, if we look at the studies out on how this adoption went of medical records, of EMRs, the verdict is still out on if they actually brought efficiency gains to the health system. It's hard to find a provider out there who loves working with their medical record. A lot of people are citing that it increases the amount of time it takes in a day to see patients, and the documentation effort that needs to be put into using the electronic health record. So at the end of the day, if we look at this policy, the policy was focused on the solution, the EHR, rather than on the root cause, which was that problem of misaligned incentives. So policy focused on how do we adopt technology to create efficiency gains rather than how do we actually tackle that root cause. But now that we know that after this time period of meaningful use, now that we have EHRs in place across the country, we're starting to see a second wave of technology adoption that's really driven based on this movement towards value-based care. So this is something that most of you on the line probably know a lot about, but we're starting to see policies and shifts in behavior in the industry that starts to align providers, hospitals, payers around the value equation, which is really looking at patient outcomes, so what is the quality of the care that's being delivered, and comparing that to what is the cost of that care. So that's that value equation, and there are all sorts of policies out there like ACOs, bundled payments, any of the capitated models that kind of harken back to the HMO days that are focused on how do we shift payment mechanisms to value-based care. And this is really starting to tackle the actual root causes of inefficiency in healthcare in the industry. It means that all parties are aligned to deliver the best possible care at the lowest costs. And when these incentives exist, we start to see intrinsic demand for technology. Because if we have true incentives around efficiency gains in healthcare, then technology is a great way to achieve those efficiency gains. Because the definition of technology has efficiency built into it. We use technology to become more efficient. So this is driving that second wave of technology adoption that we're seeing. And we call this the strategic technology adoption wave, wave 2. And in this model, really it's technology demand is driven off of the need to reduce costs or improve quality. So that we're looking at ways to actually deliver more care efficiently. So that's things like telehealth, improved care coordination across teams, allowing providers to deliver care at the top of their licenses, utilizing skilled nursing facilities, those sorts of things to keep patients out of the hospital. Which brings that to that next point there of how do we replace high-cost events with low-cost interventions? So all of the technologies out there around reducing hospital acquired infection or readmissions, monitoring patients remotely, identifying opportunities for prevention rather than acute intervention, and diverting emergency care to outpatient or urgent care facilities. And all of this combined with the need to improve outcomes. So these kind of icons here represent the swath of new technology categories that we've been seeing come to market over the past 2 or 3 years. However, what we haven't seen yet in this strategic technology adoption wave is then any one of these types of technologies crossing that chasm to widespread adoption. So, the vast majority of us still cannot video conference with our doctors, which is crazy because we video conference with our friends and family, and we're doing it right now over a webinar. Why can't we do this with our providers? It's low-hanging fruit in the industry that we think should exist. One of the challenges to getting widespread adoption is that in order for these technologies to scale across the industry, they actually have to connect up with the legacy systems that are already in place at the health systems around the country. So this is really where Redox sees our part today. We help to build this network, right, of all the new applications and all of the health systems with their legacy EHRs. How do we build a framework where these guys can talk to each other more rapidly, and we can start seeing faster adoption of this technology? So for those of you who use us today, this is the model that you're used to. We plug into Redox once with a standardized API connection, and then Redox maintains connections to each of the health systems on the other side of this. But what's interesting here, and the way that this diagram is drawn, shows a network, this networked interoperability approach. In this model, though, neither the innovations on the top side nor the health systems on the bottom care that Redox is a network. It's really just about a means to an end, connecting A to B, connecting the application on the top to the EHR and the health system on the bottom. So this is when Redox is often compared to vendors who are managing mirth for applications, which is an interface engine that can help developers process and consume healthcare. But essentially, it's really just connecting A to B in more of a model like this, where one application can connect up to one health system with a single line, rather than a networked approach like we pride ourselves on at Redox. Additionally, sometimes health systems look at us as a traditional on-premise interface engine, which is simply something designed to bounce messages around within a health system, but really doesn't bring the efficiency gains of a network. It's still customized at each health system level. So one of the main differentiators and things that allows us to have a vision looking forward into the industry is that all applications and all health systems that are connected to Redox are technically interoperable. It solves the connectivity problem as well as that standardization problem, the data normalization problem. Because if you're not solving both of those things simultaneously, you're only really making incremental improvement on the connections here. So really the goal for wave 2 of technology adoption in healthcare is really just about how do we integrate technology that's being purchased for a strategic reason at a health system to the EHRs on the other side. But as we've seen health systems do that more effectively, we've worked with dozens of health systems across the country now, and certain health systems are starting to see wins with their strategic technology adoption. So folks who are doing more and more telehealth visits, seeing that high cost, in-person care being transferred to a remote setting. The more times we see health systems get wins with adopting technology strategically, we start to move towards health systems looking at technology as a strategy itself. So this is where we're moving into what we're calling the third wave of technology adoption here. And that's really kind of looking at innovation or new technology as a strategy. So this is a fundamental difference in how health systems are beginning to adopt technology. The difference between wave 3 and wave 2 is that in wave 2, health systems are looking specifically for technology to tackle a strategic initiative. Whereas in wave 3, they're essentially looking at the innovation space and saying, what haven't we found yet? What should we be adopting? What should we be looking for that's not currently on our plates? And that's when we see health systems start to create innovation teams. We've seen the advent of the chief innovation officer or the director of innovation kind of new role start existing at health systems. This person is tasked with looking at the innovation space and saying, what should we be adopting as a health system to bring in new technology more rapidly? We're also seeing health systems partner up with accelerators and incubators across the country. A lot of academics and more innovative health systems are doing this. With that process, they're also doing direct investment, oftentimes in innovation type startup companies or technology companies. We're also seeing health systems develop their own software. They know best kind of what their providers need, what workflows are necessary to make them more efficient, and they're developing their own products and commercializing those products. So typically these types of organizations were early adopters of EHRs. They have matured in their use of the EHR and optimizing it, and they've already seen success with a few strategic adoptions of technology. These groups understand the importance of an application layer, because if they have an application layer on top of their health system infrastructure and their electronic health record, then they can more easily connect up to all the different innovations that are coming down the pipe that they know are going to exist as they see more technology. So really the earliest health systems that have started looking at innovation as a strategy, some of them have built their own API layers. This custom API, which allows new technologies, modern web-based technologies, to connect up to their legacy system. But this simply makes the problem less acute for IT and internal teams. It still means that application developers need to hook up to each health system's API. And if we take a step back and look across the industry at multiple health systems doing this, it only brings incremental value, incremental improvement to applications who are looking to scale in the space. So what's happened is that Redox has actually been pulled into a lot of conversations with health systems over the past few months about how to adopt the applications that are already integrated with Redox in a more rapid way. And I think this is a really kind of interesting place where we're at. Redox has never sold directly or to health systems. We've always worked to support the development community, the applications out there who are creating the innovative applications. These are, probably most of you on the webinar right now are the developers of applications trying to bring a solution to market. But while you've brought your solution to market, you've essentially dragged Redox as a platform with you. And it's because we're doing something bigger here, right? If you're bringing our platform with you, we can actually start to become a channel for you to other health systems that we're already plugged into, and vice versa. Each of these new health systems that becomes part of the network becomes a channel for applications that are already plugged into Redox. And that is why health systems have started reaching out directly to us to say, we understand that a lot of developers are using your product. How do we actually plug into Redox once so we can start to turn on more of these applications as they become available? So we've started to have those conversations with health systems, and I think as Wave 3 becomes more and more mature, this is where we're going. We're trying to get to a point where if we work directly with a health system and license a platform to them, then we wouldn't need to essentially sell directly to the vendors, to the innovation side of the community. The goal here is to commoditize integration. I would love it if application developers no longer had to list it as a feature on their feature set that they integrate with EHRs, because that should be a given. It should be very low on the hierarchy of needs. The value propositions that your applications bring should be what sells your product, not your ability to integrate with the legacy systems that are on premise at those health systems. And as you bring us into health systems, Redox wants to reciprocate that and eventually become that channel partner for you. We want to let you guys know where our network overlaps with your network so we can see how to help technology be adopted faster, because that's our goal. How do we help get this technology in the hands of health systems faster? How do we help some of you, those of you who are developing truly valuable products, how do we help you guys cross that chasm to widespread adoption? Because I think the only way that's going to happen is through a centralized, integrated network of APIs here. So the goal here is how can we start to commoditize technology adoption in healthcare. And once we're plugged into a health system, we're starting to see, or we predict that we'll go into this new wave 4 of technology adoption in healthcare. And this is where things get really exciting. So if you look at a health system, which we can represent as this kind of light box here, they have a bunch of different departments and committees. And if they're connected to Redox, and Redox connects them to this network of applications that are already integrated, typically the technology adoption process looks something like this, where we have innovation teams who are looking at technology. They'll bring that to various clinical committees to figure out which technology should we invest in. That, of course, has to go through IT approval, and then eventually it gets down to that department level where it can finally get administered to the actual end users, the folks on the front lines delivering healthcare to patients. This process takes way too long, right? Health systems are not currently designed to adopt technology quickly. So those of us who sell directly into health systems are experiencing 18, 24, 36-month sales cycles where we're trying to get through this process of they understand the value proposition. How do we relay that to every stakeholder in the health system so we can finally get it in the hands of stakeholders, or end users, I should say, at the front line where it's going to make a difference. The goal once we're plugged in with the health system is try to figure out how to streamline this process and get technology adoption as close to the end user as possible. We want to democratize the adoption of technology so that end users can actually make that choice to use a specific technology based on that end user's preferences, based on their workflows, based on their specialty of care, based on how they particularly want to deliver care. And that's a vision where we think this is going. Once we have a once we have a consistent way to connect up applications, normalize that data, how can we start to give providers and patients the tools they need to distribute that adoption of technology down from the high levels at the health system down to the department level and potentially all the way to the provider level themselves, where frontline staff can actually choose the best technology for the job. So the goal here with Wave 4 that we're hoping to get to at some point is to commoditize distribution of technology. We don't want technologists to have to build and maintain huge sales organizations and sit through two-year sales cycles just for their technology to get in the hands of the people who will actually save lives with it, right? It takes far too long now, and I think because of that, health systems are still so far behind in what technology is used on a day-to-day basis. Like what other industry is using fax machines and pagers? We're the last ones out there, and it's because we have this gap, this process, and too many steps involved in actually adopting technology. So our goal as we start working more and more directly with health systems is how do we streamline this process so we can distribute the adoption of technology. So to recap the 4 phases that we talked through here, and where we're going from this technology adoption perspective, the first phase was mandated technology adoption, and it brought the first digitization of healthcare through electronic health records. The second phase, we saw strategic adoption occur as incentives aligned around the efficiencies and effectiveness of care delivery itself. Many health systems are still in this phase, and in these scenarios, Redox is simply a means to integrate faster. Our goal is to stay out of the way and accelerate the adoption of successful software. And this is where we have grown our network of applications and health systems. And really with Wave 2, we're trying to figure out how do we commoditize integration. So that way it's not a product differentiator for you, but it's really a given that all technology should work with the legacy systems that are already used in premise at the health systems. As we move into phase 3, the more innovative health systems out there are beginning to see that technology is a core part of how they deliver care and are setting up the infrastructure to adopt technology faster. So we're beginning to work with these health systems to allow them to test out new applications in staging, experiment with solutions as they come to market, test things quickly, and move on so we can actually figure out what technology will deliver the value propositions that are going to actually increase efficiency and effectiveness of care. We want in this model to figure out how to commoditize distribution, which will lead us to that 4th wave, distributed adoption of healthcare applications and healthcare software. And if integration can be distributed as a commodity, meaning everyone can do it safely and securely while keeping source systems up to date, then it follows that the choice to adopt certain technology should be democratized and as close to the end user as possible. So this is where we see technology adoption moving, and I think that the core thing to point out here is that we kind of needed these steps to happen in sequence. Without the electronic health record, we wouldn't have digitized medical records today, and we wouldn't have this platform to start building strategic technology on top of. The strategic wave needed that first wave of initial standardization and digitization of that data. Wave 3 needed the second wave to get some wins with the health system to show them how innovation is actually making a difference. And then, of course, getting to wave 4 hasn't happened yet in a large way, but I think it's where we can actually end up in a world where end users can pick the best tool for the job, because they're the ones obviously who know best. But where's the patient in all of this, right? The patient is the common thread in most interoperability problems. The patient's the one moving between specialists. They're the ones being admitted to the hospital and attempting to engage in their own care. And as such, true interoperability, we don't think true interoperability will be achieved until the clinical data can actually follow a patient seamlessly and effortlessly. So this is the concept that we're calling patient-centered interoperability, and it's sadly missing from the typical discussions in our industry. So far, most interoperability discussions are agreements between different business entities saying that my health system is taking care of this patient and your health system is taking care of this patient, therefore we should exchange data about that patient. Or it's health system taking care of patient and an application or software vendor is contributing to that care, so we agree to exchange data about that patient. But the patient was not consulted in those discussions at all, and we're not going to achieve true interoperability until we can get to a point where patients can be the center of this. So if we get through these steps of creating a network where technology can be adopted quickly, where it can be distributed quickly to end users, it follows that we should be able to take that distribution and move it all the way to the patient level. And this is where I think we can start to bridge the gap between what is now called consumer health, which is really fitness type applications, and true clinical care. That gap will get smaller and smaller and smaller as consumer-facing applications are building tools that actually affect clinical care, that affect acute care settings, that help patients monitor their acute conditions. And the missing gap in here is this network that will enable consumer-facing applications to bring an application to market that delivers value directly to a patient, and that patient has the ability to authorize access to her medical record wherever it may be. So we're seeing tremendous movement in the industry around people supporting this concept that interoperability should be patient-centered, that the patient should have the right to download, to authorize use of their data, and they should be able to do this through an API so developers can build tools on top of this. Because patients do not have a direct demand for data, they have a demand for information. And it's this application layer that will turn data into information so patients can understand how to change their behavior around it and become engaged in their care. So that's where we're headed. We think that if we look at these waves, we think that we're approaching wave 3 of innovation as a strategy with health systems. We're seeing health systems across the country start to adopt that as a practice. And the reason why Redox is cloud-based, is multi-tenant, and will never go on-premise is because we understand that we need a networked approach to actually solve this problem in the long run. You can solve wave 2 building more point-to-point connections, but you can't go beyond that. So that's what we've been up to over here. I'd love to jump into questions now if you have them. So let me stop sharing my screen, and then we're going to get James in here as well because he's really great at answering questions. Here, just swing around here. So this is James, our CTO.
Yes.
Let's see what questions you guys are asking. I haven't even looked yet. And for questions, I always put on my Redox headband because things get serious. Cool. Okay. Awesome. First question. Let's jump into this. What is the difference? What is the main difference between Redox and Catalyze? That is a great question. Catalyze is a company here in Madison as well. They're actually right down the street from us. We know them pretty well. Catalyze primarily offers hosting solutions to software vendors. So if you're developing an application and you need a HIPAA compliant stack to put your database in, Catalyze offers a lot of solutions for that. And of course, the types of people who need HIPAA compliant hosting environments may also need integration. So they've come out with a product that helps people with integration. But this is what I was talking about earlier with wave 2 of technology adoption in healthcare. Catalyze's solution to help people adopt technology or help people integrate is helping people manage an instance of Mirth, which is an interface engine that can be configured to help with integration. What it's not doing is a networked model. So when you do integration through Mirth or through a managed interface engine like that, you're not connecting to a larger network. And so there's not really efficiency gains in that network. Whereas with Redox, if we're already connected to a health system that you're selling to, we can simply start turning on that data feed because it goes through the exact same instance of our engine. Whereas Catalyze, and there's a few others out there who are managing interface engines for folks, they're essentially standing up a new point-to-point connection for each new integration. So that's kind of a high level from a technology standpoint, but from a business model standpoint, we're focusing on how do we get that network growth as fast as possible to become a channel for you, whereas their business model is about selling more point-to-point connections, if that makes sense. Do you have anything to add to that? Cool. What's next here? What are some examples of apps that don't exist that we want to see developers build on our platform? That's an awesome question. Here. What do you got?
So I think I'm going to answer a slightly different question perhaps, but I think there are a lot of opportunities that we see of health systems that are expressing a need for a solution that's represented by kind of the combination of many applications that we see in the industry. So maybe the idea is combining, providing a holistic physical therapy, remote physical therapy solution. So you need to bundle telemedicine solution with an Internet of Things, smart scale or something like that, with direct scheduling component, and really seeing the thing I'm really looking forward to is seeing application developers starting to partner and coming up with creative bundles on their own that we can then be the channel for that communication on.
Yeah, I think we get really excited about when software vendors who are integrated with Redox start talking to each other. We have a Slack channel, a community there's something like 700 people in it, and most of you are developers who are creating some sort of point solution. And health systems, they see a lot of different point solutions, and they're trying to figure out ways to stitch these things together. And we love seeing when people start talking to each other about how they can collaborate. And if you're both integrated with Redox, it's very easy to start exchanging data between two different point solutions, like a scheduling tool and a telemedicine tool, for instance, could collaborate on a solution and bring that to a health system together. So at Redox, we want to get more involved in those discussions. So definitely keep us in the loop, because what we're trying to do is get to a point where we can help health systems figure out how to navigate this ecosystem of all of these applications. And if we can tell them that we can stitch together many different solutions that are top best of breed solutions for a specific workflow, then we can actually deliver something that seems more cohesive that a health system can purchase as an investment, rather than trying to navigate between all the smaller solutions. Cool. That's an interesting question, though. I think we have a few blog posts on it. We've done some thinking about like what could and should be out there. So check out our blog too. We'll move to Vikram's question here about how are we thinking about the ACA potentially being rolled back? It's scary times in healthcare, and how does that affect the business and opportunities that are out there? One of the things that it is a time of high uncertainty, right? We're not sure what our new head of HHS is going to do. There's a lot of control from an ONC perspective as well as a CMS perspective that will affect a lot of the way that payment happens in healthcare. But regardless of where the regulatory environment goes, I think the writing's on the wall that from an industry standpoint, health systems understand that we need to figure out a different and better way to pay providers and pay hospitals. And so that three-legged stool of provider, hospital, and payer is something that's going to stick around regardless of regulation. Aligning those incentives so we get that bottom line of the profit maximizing factor for that organization aligns incentives with efficiency and effectiveness for patients. So that's going to happen regardless of the regulatory environment. We might see policies around payment models change a little bit, but bundled payments are already out there. They're being expanded. We should still see that move as well. That's all going to continue to create demand for efficiency gains in the industry. The other sort of factor that plays into this from the pure economics point of view is that health systems margins have been getting smaller over the years as costs and waste is increasing. So that eats into their margins. Because of that, we've been seeing a trend of health systems acquire other affiliated health systems, try to vertically integrate across care continuum, because efficiency gains need to be had in that setting. And that's not a model that's being influenced by the regulatory environment. It's really just a business, a sort of market force that's driving on the business changes here.
Yeah, I think the only other thing I'd say is that, in terms of how it affects our business directly, I think in some ways we're a little bit shielded from it, more so than some of our customers are, because the data's got to flow either way. But I think we do have some customers that are targeting specific regulations, and if those regulations go away, I think they may be more risk than we are now.
Cool, thanks. The next question here is, does Redox take care of EMPI matching between multiple records? Do we normalize data between systems for applications to do analytics, for population health and engagement tools? There's a couple questions in there, some really cool ones. We do a lot of work with patient identifiers. So a health system will often have many identifiers for a patient. Redox will do some work to try to match those identifiers up within a health system's environment, so you get the most robust identifier object for a specific patient. We also add in another identifier, the Redox patient identifier. And this is some of the only data that we store long-term at Redox, is this string of identifiers. So we can continue to augment the data with more and more identifiers for a specific patient at a specific health system. But as far as matching patients between health systems, that classic EMPI model, that's not something we're doing yet. Do you want to talk about EMPI at all?
Yeah, sure. So we do have a number of projects going on right now they're sort of leading up towards us being able to do to take on more of this work. So it's something that's absolutely on our roadmap. Historically, when we've worked with larger health systems that may have an in-place EMPI solution, we've been able to work directly with that. But as we look at more kind of cross-health system type scenarios, we definitely recognize that's a burden we're going to have to take on here inside of our platform, and happy to do so. And inside of the question of what do we normalize between systems, so our API is definitely meant to be standardized across different health systems, and so there are plenty of cases where you may see choices. So for example, patient's race or things like that, where you may see different implementation specific variants. Those are things that we standardize and normalize across all of our data models and handle that mapping. So in general, you can't expect a sort of standard set of data and available fields and options within those fields.
And as far as population health and engagement tools, there are a lot of applications built on top of Redox today that cover those areas. One of the challenges with analytics, kind of at a base level, is you need essentially a shadow database of the EHR, so you can slice and dice it and query for different patients. We do have a limited amount of query capabilities into the EHR right now, but that's something where over the next year, as we look to expand our API functionality to give you more and more query functionality, so you can start asking questions of the data rather than just receiving a fire hose of data, as most integrations support today. Okay, let's get to Adrian's question here. Does a patient have direct access via API into Redox? What a lovely question. We obviously, and as I kind of talked about, we're really passionate about trying to figure out how to give patients access to their clinical data. One of the interesting things, though, is that patients typically don't have demand for an API, right? They have demand for applications to be built on top of that API. So we want to get to a point where we can start offering that functionality to application developers. So a developer can create an application that delivers a value proposition to a patient, so a patient can download that, use it on their phone, and authenticate themselves and receive data from the health systems that they receive care at. But that requires a big enough network, so we know that the patient will find themselves in that network, and then it requires the applications to be built on top of it. So this is kind of where we are going as an organization. Right now, we're in the phase where we are building our network, and that network's getting bigger and bigger every day. We're processing nearly 1 million clinical messages every day, and that network is built on the backs of the innovations currently sold into the enterprise, rather than being sold directly to patients. And as that network gets bigger, our goal is to someday get to a point where it's big enough where, at least in a given region, we can start saying to developers, if you make an app for the New York region or for the Bay Area region, it's most likely that the patient that downloads this application will exist in that. That's going to require a little bit different functionality from the API perspective, but that's functionality that we'd be happy to build if the network is at a point that we can actually support that. Did you want to add anything to that?
Yeah, I think just the reality of the scenario right now is that that's definitely the place that we're building towards, and there's different components of MACRA and some other regulation that have suggested a path forward from the sort of legislative side of things. We're typically not ones to kind of wait around for that kind of side of things that foot to drop. So basically the state of affairs today is that much of what is getting exchanged is coming through direct business associates agreements and things like that. And so as we look to shift more towards the trust being on the individual application and the individual user, shifting away from the systemic trust system, then I think we'll start to see more of this.
Cool. Okay, Vikram, you've been asking some awesome questions. Thank you. Let's do your next one here. What's the pushback we're getting from health systems right now? How should developers think about the risk of developing on our platform if a health system goes elsewhere, doesn't want to use it? That's an awesome question, because if you do the work to integrate with Redox and the health system doesn't want to actually integrate with Redox, then that'd be a lot of waste. So we are very sensitive to that problem, and actually right now in the majority of our implementations, we've been brought in by the application to the health system. So we oftentimes in those situations stay kind of behind the scenes. We work with the health system directly to set up the infrastructure, but it's your customer. The health system is your customer, not our customer. You're the one who sold them on the value proposition of your product, and we are simply the means to connect your product to their system. And the way that Redox does that is very efficient for the health system. So most of the time, they're very happy to work with us because we tell them, we meet them where they are, essentially. We connect in the ways that health systems are comfortable connecting. And that's, goes back to our experience with working with many health systems and their IT infrastructure in our prior lives with different healthcare and EHR companies. And we also use their specifications. So we're not asking health systems to do any work from a data perspective to map their interfaces to Redox or anything like that. Redox does all of the work to say, what does your interface situation look like today? How is data being released from your health system? And we will do the work of mapping that to our models. So health systems are typically able to reduce the amount of time that it takes to do an integration with a cloud-based product by magnitudes by working with us. So we're going into these situations and we're not charging the health system. We're not going into a contract negotiation with the health system. We're simply saying, we're going to make your life really easy here. These are the 5 steps to do that. and the project you thought was going to take 6 months, we can actually go live with in 3 weeks. So we haven't really gotten pushback from the health system saying that Redox is preventing them from wanting to go forward with the project that an application brings in.
Yeah, the other piece that I'd add to this is that, up front, we have a customer success team that really will help you as an application developer scope out your project and really help define how to talk to a health system about it. So some of the pushback we see from the health systems give applications, maybe in a scenario without us, would be that the application is trying to kind of bite off more than they can chew in their initial phase. So, asking for basically all of the data without really having a business use case for it. So part of the service we provide is helping clarify and understand what that initial scope is and how you might be able to phase out maybe 2 or 3 different stages of asking for more and more data. So maybe accepting a read-only phase first, and then moving into a writing back phase or something like that, where you can start to make the project more palatable to the folks at the health system IT team.
We call this scoping process the integration project of least resistance, where we try to get you live and integrated with something quickly, and then iterate on that to get to all of the bells and whistles that your product could potentially provide. So it's a process that we collaborate on as you're working with a health system, as you're getting into that implementation. Okay, we had some more votes here on other questions. That first one we answered already. I just forgot to say that I was answering it. So let's do this one. So are your integration partners on either side concerned about Redox downtime or messaging breakage? How do we deal with that potential problem? First answer is yes. People are concerned with that. It's probably the highest priority at Redox to make sure that we don't have downtimes. A lot of the applications that are used are, or could be life or death, right? We're working with applications like Gauss that's used in the surgical setting, where there's literally someone on the table who's cut open, and if the software isn't working appropriately, could influence complications into that surgical setting. So it's of super high importance to make sure that this thing is stable, that we don't receive any downtime, that we're monitoring and notifying people if there's any errors and things like that. I'll let James answer, how do we deal with this problem?
Yeah, absolutely. Yeah, so we do spend a lot of engineering time on just our availability and our responsiveness and performance. There's, and I would say more broadly, connecting, being sort of the layer between a health system and an application, there's lots of things that can break that are even outside of our control. And so we provide a lot of proactive monitoring too around the connection into the health system, the actual servers inside of the health system, and our connectivity to those applications. And we have a lot of proactive monitoring notification. We'll reach out to, oftentimes we're actually the first one to find out about one of our application partners having a downtime because we see that we're not able to ping their side. So yeah, we care a lot about it. In terms of message breakage, anytime we see something where maybe there's a downstream system that we're not able to contact, we queue up messages so that we maintain the order of that. We know that messaging in the healthcare setting is order matters. Getting admitted and then discharged is very different than getting discharged and then admitted. So we definitely have to maintain that order, and we do so inside of our engine if we see a health system or an application that's having a downtime. Furthermore, we have from sort of a notification and responsiveness side of things, we have a status page that our application customers and health systems can subscribe to, and we maintain ourselves on many of the health systems outage list and interface maintenance lists, so we're up to date with what they're doing maintenance wise too.
Do you want to add at all about how we deal with variances in volume, because that can definitely affect some of this, where there's a huge spike in volume from a health system? Sure,
yeah. So as Nico mentioned, we do have sort of this centralized network approach, but on the inbound side, we do have basically a queue per source of data. So health system A may send us a message every second at a pretty steady rate, and health system B may drop 100,000 messages at our doorstep at the beginning of every hour, and then nothing for the rest of the hour. And basically, we kind of round robin those inbound queues so that we don't have a noisy neighbor problem of that health system B slowing down everything else from health system A. And so that's our general approach. We also have some more sophisticated monitoring and infrastructure behind looking at queues getting backed up, and are able to kind of scale out our message processing infrastructure if we see that things are starting to get slowed down.
So I hope that satisfied all the back-end nerds on the line. What else do we got here? Okay, Dan asked about being excited about the third wave, which was for review, the wave that that allows health systems to distribute the choice to adopt technology down closer and closer to end users. And Dan, I think you hit the nail on the head that there would need to be a marketplace style approach, because marketplaces are typically the way that that technology is distributed. And so we've been actually testing out a sort of marketplace approach for a while now. Timur added the link there. We have a gallery that lists the various applications that want to be listed on there who have integrated with Redox. So once you're integrated with our platform, we give you that ability and option to list yourself on the gallery. The gallery really for us is just different examples of types of applications that are integrated. But whenever we talk to health systems, whenever we go into those meetings with health systems, we bring the gallery with us. We pull it up on the screen and say, these are the different types of applications that are here, the different types of solutions on the market. And if someone has a question about telemedicine, we hit the telemedicine filter and we say, these are 5 examples of telemedicine applications that that are integrated with Redox. I think there's like 70 or so different applications on the gallery right now. If you're integrated with Redox and you're not on the gallery, let us know. It's a flip of the switch and we can get you on there. We don't have a marketplace model right now. Like, we're not charging 30% of your revenue like Apple does. There's a lot of marketplaces that have that kind of model. We really just see the marketplace as a way to more easily distribute your technology. And of course, we have our typical integration as a service model. Cool. Do we have plans to operate in Europe?
You want to take this one? Or?
Yeah, you do it.
So Europe's interesting. Europe is a continent, but it's not one country exactly. So we do actually have some health systems live in the Netherlands, but there are some interesting data sovereignty policies that are pretty widely across the different countries in Europe. So safe harbor countries are ones where we can support from our US data centers. Places like Ireland and Germany, for example, are ones where they have very strict data sovereignty rights, which means that we would have to run our own data center in those countries. So that's really the kind of barrier to entry that we've seen, is just making sure that we can find a critical mass of companies and health systems that are interested in an integrated product and in using Redox to kind of warrant us spinning up a new data center in one of those countries. And just to tack on, I think the same thing is true of Canada, actually, with that data sovereignty right, and that's actually probably the next place that we're going to expand out from a data center kind of perspective.
Did you just call Canada Europe?
Yeah, that's the same thing.
Cool. What else do we got here? Oh, I like this one, Nick. What are the favorite tools used by the Redox team?
Cool.
We have a lot of, we use a lot of fun tools. Crowdcast, I love Crowdcast. I don't know if you guys are enjoying this, but I love that you don't have to download anything to your desktop. You can just do it in browser. This question and answer feature is really cool. A lot of you use Intercom, which is our live chat tool that Annie's on the other side of that a lot of times. So you can chat with her there. We love Slack. So I mentioned earlier, but we have a Slack community of developers and technologists who are building apps. We use Slack religiously internally in the company, but we're trying to get more of our users to interact with us on that. So feel free to sign up there and post there. Feel free to post whatever you want, relevant to the space or funny is fair game too. I love Calendly for scheduling meetings. So if you've ever had a direct call with me, you've probably scheduled it through Calendly. Actually, after this, we're done here. We'll send out a follow-up email with a link to Calendly if anyone wants to have a direct, conversation with us, two-way conversation with us. So you can do that through that.
From a developer's side of things, we have a remote team, so about half of us are in Madison, Wisconsin, and the other half are kind of distributed throughout the U.S. But we're passionate about doing pair programming, and so there's a really great tool that was actually acquired by Slack about a year and a half ago called Screen Hero that we use to do remote pair programming. So two people can be in very different locations but still control the same machine. And then also, we really like the tool called Postman. It's a great way to interact with an API without having to spin up much of an infrastructure behind it. So we have a Postman collection that's downloadable from our source dev tools, but it's a great tool in general in interacting with APIs.
Cool. And I think we'll, let's see here. Okay. Yeah. So George asked, do we foresee joining interoperability associations like Sequoia, Carewell, or Commonwealth in the future? Would there be an advantage to that for us? I think Care Quality is the Sequoia one, but yeah, absolutely. So Redox is an active member of Commonwealth right now. We beyond abiding by Commonwealth specifications. And being able to interact with Commonwealth, we actually help a lot of software vendors figure out how to use Commonwealth more effectively. So Commonwealth is a network that allows an EHR vendor and a patient sitting in front of a provider to query the network and figure out if patients exist elsewhere and pull that data back in. So it's a really core piece of interoperability from the care coordination, or not care coordination, from a continuity of care point of view. And so we're definitely involved with that. Care Quality does something similarly, but without the network, more with a unified specification on how to do that exchange. We abide by that as well. And actually, I've been having conversations with Care Quality to figure out how we can collaborate with them more. So these organizations are really important. They are not competitive. They don't compete with each other, and we don't compete with them. These are all different sort of pieces in the set of solutions that will actually solve this interoperability problem in the years to come. So we're happy to support them and be a part of them. Okay. I think we are running up to the hour, which is where we wanted to end this thing, and we got through all the questions that had votes. We're going to comment on the questions that we didn't answer live here today with some answers or some links to resources for them. Thanks so much for coming out and hanging out for the webinar. This will, like, literally right when I hit end, the video will be up and running on this exact same website, so you can check it out there. We'll probably link to it from our website as well. But thanks so much for coming out. You're going to get a follow-up email from us with additional resources and ways to interact. So watch out for that here later today. But thanks a lot. Now let's see how to turn this thing off.